everyone. Thank you for joining us today for this webinar. We have Dr. Timothy Kosinski. Tim is a friend and colleague, and he's a very well-known implantologist. Dr. Kosinski is an affiliate adjunct clinical professor at the University of Detroit Mercy, and he serves on the editorial review board of Reality, the information source of aesthetic dentistry, and is the past editor of the Michigan Academy of General Dentistry. He currently serves as the associate editor of the AGD journal and is honored to have been named editor of Implants Today, the implant publication of Dentistry Today. He wrote many articles related to implants. Also, he is a fellow of the American Academy of Implant Dentistry. He also received his mastership in the Academy of General Dentistry. Dr. Kosinski received many honors, including the fellowship in the American and International College of Dentists and the Academy of Dentistry International. In 2017, he received the Academy of Dentistry International Humanitarian Award in recognition of significant contribution to the enhancement of the quality of life of the human condition. Now, without further ado, I would like to introduce now Dr. Tim Kosinski. Tim, go ahead. You can share your screen and the microphone.
I believe everybody can see that now pretty clearly. So, Gabby, as he said, Dr. Caspo said, we've worked together actually in the same building for many, many years, and Gabby is very humble, and he is also a phenomenal lecturer and a very talented person. So he asked me to do a program that we entitled Aesthetic Implant surgery, and what I'd like to do is go through, really it's just two cases, but some of the issues that we have in the aesthetic zone that we're able to achieve a pretty good result, at least predictable results. And what that means is, as we know, our labs are very important to us, and our lab technicians are very important to us, but in today's dentistry, pretty much everything is CAD/CAM design. And we can pretty much predict the end result prior to any surgical intervention. And when Gabby and I first started, that was really an art in dentistry. Visualizing the case finish before you ever started, that took years and years and years of clinical trials and work until you got more proficient. But in today's environment, with the advent of CBCT analysis and software that Gabby is so versed in, we're able to actually design our cases pretty much before we start and showing the patients what we're able to accomplish. Some of our cases are more challenging. Some we do have aesthetic concerns or compromises. But again, if we follow certain rules, and it really is rules, we can achieve some outstanding results. So, as Gabby said, I practice in Michigan, in the suburbs of Michigan. I love my dental school, one of the finest dental schools in the country, University of Detroit Mercy. And a lot of, Dr. Caspo mentioned that I do publish a lot. We've published about 210 articles, and we've done a lot of video demonstrations. And if you're interested in all and seeing some of the things that we do, you can go to DrKosinski.com. That's my education website. It has my articles published, and my video demonstrations, and a lot of the surgical applications that I'm going to show you in slides today. So if you're so inclined. Gabby gave me some objectives, and we're gonna discuss specifics in creating interdental papilla in the smile zone, in the aesthetic zone, in the pre-maxillary zone. And we're gonna learn about complications that can occur in this anterior area, and we're going to learn how to effectively use custom components to get a predictable result. So really specific objectives with this case demonstration, and I hope you enjoy it. So this patient presented to our practice with a broken tooth and with a flipper, removable appliance. And he heard about us for whatever reason, and obviously the advent of the internet has changed the way we discuss implant dentistry. Obviously our patients are are Google searching missing tooth, broken tooth, I hate my denture, I hate my partial, and what pops up is dental implants. So we have a differential diagnosis. I mean, how would you treat this in your practice today? Some of us may say, well, root canal, post and core, cast post and core, crown lengthening, aesthetic area. But if we were able to achieve this result, how do we achieve that result? How do we customize the final result to get our patients very, very well motivated in the final result? In other cases, patients break their anterior teeth. How do we fix it? Are we able to restore them with conventional dentistry and or implant dentistry, which is all the rage today? What about this interesting case? Half the arch is healthy, half the arch is in really bad shape. Obviously, the patient's seen a dentist before, trying to maintain things. And are we able to achieve this kind of result predictably with our implant dentistry? And I challenge you to say, yes, I think we can provide our patients some really high quality dentistry at a reasonable cost. It doesn't have to be expensive because, again, our lab work is all CAD/CAM designed today. So aesthetics with implants, it's outcome based. Both dental and gingival aesthetics act together to provide a smile with harmony and balance. A defect in the surrounding tissue or bone can be compensated, though, by the quality of the dental lab work that is done. What does that mean? Well, we often know that patients have issues where they don't have interseptal bone. If we don't have interseptal bone, we don't have interdental papilla. We don't if we don't have interdental papilla, we compromise our aesthetics. We have to make teeth wider than normal. We've all seen that. We've seen people walk in the streets with teeth in the aesthetic zone that just don't look right. But we can compensate it, maybe do a veneer, try to balance things and an adjacent tooth. So there's a lot of tricks that we can use to maximize aesthetics. So where do we ultimately want to place implants? And there's rules that we teach in our courses. We have courses in Charlotte, North Carolina. We have a teaching center there called the Engel Institute. We have teaching centers in California and Louisville through Glidewell Lab. So there's a lot of information there where you can get really proficient in some of these techniques that we're talking about. Well, it's very, very important, especially in the aesthetic zone, that we place our implants correctly. We need at least minimally a millimeter of facial or labial bone and lingual bone in the aesthetic zone. The more bone we have, the better the end result. We've all seen cases where an implant is placed in the aesthetic zone in the premaxillary area, and we have gray shadowing, the implant showing through. So it's imperative that we have at least a millimeter of facial bone to work with. More is better. We used to, when Gabby and I first started, we used to say put the longest, fattest implant we could in a certain situation. And that's certainly not the case today because our engineering principles and our mechanics are much better than they were when we first started. So in today's environment, more bone, less titanium is the rule. Mesial distally, again, we have rules that we must follow. We cannot be any closer than 2 millimeters from a natural periodontal ligament. And if we have multiple implants, these implants must be spaced at least 3 millimeters apart. And that's because an adjacent tooth, a natural tooth, has a PDL and has a blood supply where implants do not. So again, rules that must be followed. The papilla level around single tooth implant restorations is mostly related to the bone level adjacent to the teeth, more specifically to the bone height. And what does that mean? So we have to talk about that specifically. Peri-implant bone remodeling always occurs vertically and horizontally once the implant is exposed to the oral cavity. We've all seen that, right? We place our implant at the crest of the ridge, or some of us put it subcrestal, and it looks that way as it osteointegrates and it heals. But once we expose it, we expose the implant, we take an impression, we put a healing abutment in, we normally physiologically will see 1 millimeter to 1.5 millimeters of bone loss during the first year. And this remodeling occurs due to the effect of biologic width. It's a condition that is physiologic, and we have to expect it. So when we teach, please don't be critical of dentists who have placed implants in the past. Again, our engineering principles have changed over the years. But again, we do have a physiologic response that is expected in our cases. So for all of you here, we just took this out of a textbook with Dr. Tarnow, is one of the leading educators in implant dentistry. And I want you to focus on the interdental contact area between the two central incisors. On average, it's about 4.2 millimeters. So I want everybody to remember that number, 4.2 millimeters. The contact dimension between two central incisors on average, 4.2 millimeters. So let's go back to our patient. So this patient presented to our practice with a broken tooth and read about implants, came to us, already had a flipper made, and wanted to consider a dental implant. But again, we have a differential diagnosis. Maybe some of us would want to do a root canal, maybe a post and core or cast post and core, conventional crown. Let's look at this again. Do we really want to do this? We have some recurrent decay here. And obviously, I felt that this was a good indication for a single dental implant long term. We all know cast posts and cores are wonderful, but we also know that at least I know that I probably place more implants on teeth, root canal treated teeth that have posts and cores in them than anything else. So we do our CBCT analysis, and the CBCT obviously is an outstanding tool that helps us to do some evaluation of the quality and quantity of bone that we have to work with. I want you to focus in on the facial plate of bone in this area. You can see it's very thin. It's eggshell thin, all to the point. So some of us, when we're doing our extraction techniques, we find that we fracture the facial plate of bone, or we feel that we fracture the facial plate of bone, and we have to determine how do we resolve this issue. Now, this is not a bone grafting course, and maybe Gabby will invite us back and we can do a grafting course. We can certainly grow bone today. We have the techniques and the know-how as long as we follow certain rules. But this is a challenging situation in the extraction and the final position. But we also know that we do have available vertical height of bone to be able to place an immediate implant. And we do have some adequate width, nearly 8 millimeters of adequate width of bone to work with. And we're going to go through the rules of placing our implant in this position following the extraction. So again, let's look at this occlusally, and we can see we do have a tooth that I deem to be non-restorable. The patient agreed that we would remove the tooth, graft the site, place an immediate implant, and I would allow it to heal because the patient had a flipper. I would not immediately load this case, but we would let the patient wear the flipper for a period of time and try to maximize the aesthetics. Now, this is a forceps that many of you may have heard me speak on or learned about. It's called the physics forceps from Golden Dent. Again, I have nothing to do with the company. I have no financial interest, but it is a Detroit-based company. It's a series of 4 instruments that allow me to atraumatically or minimally traumatically remove this tooth. Now, this is very, very important. It's an instrument that has 2 components. The beak is the shovel-shaped edge that will engage the palatal aspect of this tooth, 1 to 3 millimeters subgingival. The second component is called a bumper. And this is placed as high up the vestibule as possible. It is not the working end of the instrument. It's not holding the facial plate of bone. It is simply acting as a center of rotation or a fulcrum, which allows me to create tension on the palatal aspect of this root, which will allow me to disengage. The tension will create a physiologic response, which will cause an enzymatic release, which will break down the periodontal ligament. Once the periodontal ligament is destroyed or melted away, the design of this forceps will allow this tooth to disengage up and out of the socket, maintaining the facial plate of bone pretty routinely. We are not squeezing the handles. This is not truly a forceps. It really is more of a luxator or a modified class 1 lever, which it's just an instrument that I wouldn't practice without it. Again, whole nother course that we could discuss the use of this physics forceps. But I'm able to remove this tooth atraumatically, meaning I was able to maintain the mesial distal and palatal bone structure. And I was also able to actually maintain that very thin, eggshell thin facial plate of bone. Now, if I didn't use this instrument, how would we, or our audience out here, normally remove this tooth? Well, I would probably say that most of us would take a periotome and go around the tooth to try to break down the periodontal ligament. I am assuming that many of us may take some type of a luxator or elevator and go on the mesial or distal part of the tooth and try to wiggle the tooth out a little bit. Then we would take some type of forceps, an anterior forceps, grab onto the tooth, squeeze onto it as heavily or hard as we could, rotate figure 8, mesial, distal, buccal, lingual, however we would normally do it. Good chance you would break the facial plate of bone. Now, what if you couldn't get a purchase point mesially or distally? Well, I challenge that most of us would probably take a surgical burr, a 557 surgical burr, and trough the mesial or distal bone. That's where the problem is. Bone is gold to me, especially in the aesthetic zone. And the interseptal bone is especially gold to me. Without interseptal bone, I cannot have interdental papilla, period. You must have interseptal bone to have interdental papilla. So removing the tooth is very, very important. So we went back, we atraumatically removed the tooth, and we take a periapical radiograph to ensure that the tooth is removed in total. It is. I'm looking at the facial plate of bone. I'm going to move my screen over a little bit, and you can see that the tooth is removed in total. No, did I lock in? There we go. So here I'm looking at the tooth, and I'm assuming we're still okay, Gabby? And we're looking at the tooth, and I'm going to determine the length of implant that we want to use. And I'm simply measuring that root, and then I have a series of drills. This type of implant that you use is really irrelevant. Here I'm using the Glidewell Hahn implant, which is my favorite go-to implant. It's very aggressively threaded surgical burrs, which allow me to very, very aggressively place the implant very predictably. So now this is very important. I'm taking my pilot burr, which is a 2.4 diameter burr, and this positioning is very, very critical. I do not want to place that implant directly into the socket site. Why do I say that? Well, because we remember how thin the facial plate of bone is. I do not want to place my implant exactly where that root is. Rather, I want to place it about 3 millimeters palatal to the facial aspect of the adjacent teeth. I want to place my pilot burr about 3 millimeters palatal to the facial aspect of the adjacent teeth. I want to engage the palatal bone. So I'm going to have a gap on my facial aspect. I also want to angle it so that my access will come basically in the cingulum area where possible. So again, I don't want to place that implant directly into the socket because that facial plate is very thin. So I'm taking my pilot burr, which is really my working burr. It's the most important burr in the mouth, and I'm simply going to place the implant beyond the apex of the tooth, engaging the palatal bone to create stability. Now at this juncture, I'm going to go ahead and take a radiograph, and I'm looking at visualizing the final crown. I'm not thinking about placing my implant. That's pretty routine. I'm thinking, what is the final crown going to look like? So I'm looking at my mesial and distal space. Am I in pretty good position here? Can I improve it? I really want to idealize the position with this very aggressive 2.4 diameter pilot burr. And you can see my position is on the palatal aspect of the socket, not engaging the socket completely, on basically the palatal aspect of the bone. I'm taking my radiograph to ensure that my dark space mesial and distally is basically even. Again, I'm trying to think tooth up rather than implant down. Then I'm simply going to widen the osteotomy. Again, this is not an implant training course. It's more of how to maximize our aesthetics. And in the Hahn system, I'm simply going to widen the osteotomy with my osteotomy burr. Again, very aggressive. I'm drilling at about 1,000 RPMs. And I'm going to position my burr in the proper angulation that I created with the 2.4 diameter burr. And then here again, I'm going to widen the osteotomy to my final osteotomy burr, which is the 4.3 diameter burr. And again, I think it's very helpful if you take radiographs to make sure you're in the proper position. Now, when I take a tooth out, I'll tell my patients, when we take a tooth out, the socket is shaped like an egg. Our implant is round. So we're going to have a gap. The gap is going to be basically on the facial aspect of that socket. So here I'm going to graft the socket, and here I used a material from Implant called Osteogen. It's a calcium apatite material. It's a synthetic material that's very similar to natural bone. It's a material that is phenomenal. It's relatively inexpensive for us to use, and I get tremendous results. I've done a lot of histology over the years, and in a very short amount of time, this material will convert to natural bone. So I took this little plug, and I'm actually placing it into the socket. I'm placing it firmly, condensing it firmly, but it's not amalgam. I'm not crushing it. And because I've already done my osteotomy, I'm going to go ahead and thread my implant directly into this material. And what that's going to do, it's going to spread that material, mesial, distal, and facial palatal. I'm threading my implant into position. And with this particular implant, the implant should be about 1 millimeter subcrestal when we're doing an immediate extraction or immediate placement of an implant. If we have a healed site, then the implant would be placed at the crest. It's a very unique in that we have a 1 millimeter polished titanium machine collar, which Dr. Hahn created because we expect to get 1 millimeter of bone loss around that implant, and we don't want the roughened titanium exposed. Now, the implant was torqued properly. The implant's going to be buried because, as I said, the patient was wearing a flipper. But I decided to go ahead and take an impression at this juncture, immediately at placement. And you can see how this impression post fits into the implant. It's called platform switching, which is a pretty common term in our implants today. All our prosthetic components are going to be inside the outer diameter of the implant. And what we're trying to do is trick the body physiologically to prevent bone loss on the outside of that implant by having all our components inside of the implant. It's called platform switching. And again, our implant, you can see how it wasn't placed directly into the socket site. Remember what we said, we wanted at least 1 millimeter of facial plate of bone. I have 1.1 at the apical portion. But again, let's think, when you see implants that show gray shadowing in the after healing, where do you see that gray shadowing? At the crestal portion. We have adequate facial plate of bone here. We have a grafted area, which I know will convert to bone in a short amount of time. Because the patient wore a flipper and I'm not going to immediately load it, I'm going to go ahead and put a closure cap or cover screw on this site and bury the implant and let it heal. Now, this is very important. Dr. Tarnow is brilliant, has done more education, and I'm going to slow down. I know I talk very quickly. The distance from the base of the contact point to the crest of the bone correlates to the presence or absence of interproximal papilla adjacent to the single tooth implants. When this distance is up to 5 millimeters, the papilla was present almost 100% of the time. Increasing this distance from the contact point to the bone height greater than 5 millimeters results in unpredictability filling in the interdental space. What does that mean? So interseptal bone is critical. If we measure from interseptal bone to the contact point, and that number is 5 millimeters or less, interdental papilla will grow nearly 100% of the time. If it's greater than that, because we had bone loss, well, then we're not going to have interdental papilla no matter what we do, and we have to compensate for our aesthetic concerns in other ways. So let's do some measurements. This happens to be, we're using our DEXA sensor with our ruler. Most systems, digital x-rays have this ability. I can actually measure, eliminating foreshortening or elongation. This implant I know is 13 millimeters long. If I measure from the mesial, the tip of the inner septal bone, and again, I maintained it to the contact point, we see that it's 5 millimeters. So I could predictably state that I should have interdental papilla. Now, when you're working with a quality dental laboratory, we work with Glidewell Lab, the implant technicians there are phenomenal. They understand these principles. And as I'm explaining to them, to the technicians, we know what we can kind of predict what the end results are going to be prior to any surgical intervention. I took an impression at the time of surgery, as I mentioned, and we sent it to the lab, and then everything is CAD/CAM and digitally designed. So they designed the abutment, they designed the biotemp crown, or the final Bruxer crown in this situation. So we can discuss it. They can send this to me. We can do a discussion of contours in the aesthetic zone to really maximize the aesthetics that I'm envisioning talking to my technicians. Just amazing technology. So what the lab did is they fabricated a transitional or temporary custom abutment. I use custom abutments, especially in the aesthetic zone, because I want my margins to be at or slightly subgingival all around. If I use stock abutments, then some areas may be deep, some areas may be supragingival, some areas may be subgingival. And they fabricated a biotemp for me that we can try in for aesthetics. So after 4 months of integration, I'm going to go ahead and expose the implant. I'm going to expose the implant, and this is a tissue punch from Salvin Dental. I'm just simply removing some of the tissue there. And you can see the little closure cap, and I'm removing the closure cap. And at this juncture, what I'm going to do is I'm going to go ahead and place that custom abutment, temporary abutment in the mouth. And look at my margins. My margins are at or slightly subgingival. And if you see any of my lectures, all my cases are like this. And you can see how we're contouring that temporary abutment to basically be the shape of the tooth. Now, why is it imperative that I said that we place our pilot burr 3 millimeters palatal to the facial aspect of the adjacent teeth? Well, this is one of the reasons, because we have to have room for a custom abutment, and we have to have room for the final porcelain work that we're going to create. So again, we're going to take a radiograph, and we're looking at the implant. And again, our components are all platform switched. Where all our components are inside the body of the implant itself. And I'm going to torque it to 35 Newton centimeters. With this system, we torque to 35 Newton centimeters. And we place our biotemp. Not that great, Kosinski. You know, oh, wait a minute. You have a dark triangle between the two front teeth. Yeah, we do. Give it a few minutes. It will close. Physiologically, it will close. This patient wore this temp for 2 weeks. And you can see we created an interdental papilla because physiologically I had 5 millimeters between the tip of the interseptal bone to the contact point. The distal aspect, that tooth was malpositioned a little bit, and we don't have that interdental papilla there, but I didn't expect to have it there. And that's why my contours are a little bit different on the distal aspect. Lingually or palatally, you can see that because we used a custom abutment, our position, or our shape is basically like the shape of a natural tooth. Now, the laboratory also fabricated a custom impression coping, and you can see it's shaped exactly like the temporary abutment that was created. So I took the temporary abutment off, I took the temporary biotemp off, and I made a new final impression. And we worked on shade a little bit. I replaced the temporary abutment. You can see the tissue health in that area with margins at or slightly subgingival. And we replaced that biotemp for the next 3 weeks while the laboratory was fabricating the final zirconia abutment and final Bruxer aesthetic crown. You can see the beautiful tissue cuff that is created. This is very periodontally sound, very, very healthy for the patient's maintenance. The patient returns, we remove the temporary abutment and the biotemp, and I place a zirconia final abutment. And again, look at my margins. They're at or slightly subgingival. Our contour is basically shaped like a natural tooth. Our implant was placed about 3 millimeters palatal to the facial aspect of adjacent tooth. Now, some of you may ask, could we have done a screw retained prosthesis here? Yes, we could have, because our access hole would have been on the cingulum. Here, I elected to do an abutment and a cement-on crown. And our final Bruxer aesthetic crown. Bruxer is wonderful. The aesthetic area, we can do custom staining on it. And I think we achieved a very, very nice final result for our patient. Lingual contours are appropriate. And let's do some measurements here. So from the tip of the interseptal bone to the contact point was 5.02 millimeters. From our top of our abutment to the contact point was 2 millimeters. And the contact point itself was adequate for our final positioning and aesthetic creation. So we had a patient that was pretty satisfied with the final result. We created form and function for the patient. We were able to achieve things with implant dentistry to a high level. Again, virtually designing the case prior to any surgical intervention. This is nothing magical. I'm nothing magical. This is something where we're working with high quality lab technicians and achieving the results that we want. Let's go through another case. Again, a maxillary anterior where we did an atraumatic or minimally traumatic extraction, grafting, and a membrane and immediate placement of an implant. Again, we have a tooth that is deemed non-restorable, not very, very strong. And the patient already had dentistry in the anterior that we had to match. So we're simply going to, I'm going to back up here. I apologize there. Whoops. Sorry about that. Sorry about that, everybody. So same thing, we're going to remove the tooth atraumatically and follow the same rules that we've done in the past, taking our 2.4 diameter pilot burr, not placing it into the socket, but rather using the palatal aspect of the bone, going beyond the apex, and placing this burr about 3 millimeters palatal to the facial aspect of the adjacent teeth. Again, I'm going to stop and take a radiograph, making sure that our position is where we want it. I can, if it's not, if I'm mesial verted or distally positioned, I can change it. This is the most important burr that I use for length and for mesial distal positioning. I'm thinking tooth up, doctors. I'm not thinking implant first. Here we widen the osteotomy with a 3.0 osteotomy burr. And then we're simply going to take our widening, our osteotomy burrs, a 3.5 to a 4.3, and we're going to widen that osteotomy. Again, the implant's going to be placed in an immediate extraction site, 1 millimeter subcrestal. Just rules that I consistently follow: widening the osteotomy with a 4.3 diameter burr. Again, positioning it about 3 millimeters palatal to the facial aspect of the adjacent teeth. I'm very, very consistent in my rules, looking at mesial distal spacing. There's no reason why our cases should not be as ideal as possible. And again, I grafted the site and I'm threading my implant directly into that graft material. So that graft material is being pushed onto the walls. I'm able to place the implant and then use my torque wrench. This implant was torqued to 35 Newton centimeters, and you can see my position is approximately a millimeter or so subcrestal into that socket. Because I was able to achieve 35 Newton centimeters of torque, in this situation, I placed a 3 millimeter tall healing abutment. And a healing abutment is used to train the tissue, to eliminate the need for a secondary surgical exposure of the implant. And we torqued that to 25 Newton centimeters. And here I made an Essex retainer using the patient's crown. He came in as an emergency patient. And we just used the Essex, we used his old crown as a pontic in the Essex retainer that the patient wore pretty predictably. Again, a postoperative CBCT for education purposes. You can see my position was not where the socket was. If you remember how unhealthy that tooth was, you can see we have very, very nice facial plate of bone to work with, and I would expect that we're going to get an outstanding result. Now, doctors, if you do have a CBCT in your office, then when you're doing your pilot burr or your osteotomy burrs, you can stop and take a CBCT to make sure you maximize the position, your angulation, if you're not sure. 4 months post-op, you can see how the tissue healed around the healing abutment. And we will torque test this using which is something called a penguin. And what we do is we simply thread a little pin, a magnetic pin, and we get magnetic resonance. And if we get anything over 70, this implant is fully integrated, and I will feel very, very comfortable going ahead and placing my implant. So it's called a penguin, or you can use a torque wrench to torque test it. We always torque test our implants prior to making our impression. So here we're going to do a digital scan. So we put our scanning pin in this area. We send it to the lab, and I can actually get this back from the lab within 2 or 3 days. They will fabricate a custom abutment and the final Bruxer crown, Bruxer aesthetic crown, pretty predictably. So you can see the nice tissue height. We fabricate here a gold-plated abutment. You can see my margins are at or slightly subgingival, and the final aesthetic Bruxer aesthetic crown is pretty amazing. Sorry about that. And we get a patient that is pretty happy with the final result. So we're able to provide form and function to this patient pretty routinely with our dentistry. Again, it's following certain rules that must be followed, must be maintained. You have complete control. You know, as general dentists, we're the gatekeepers. We really understand aesthetics, and when you start thinking tooth up or tooth down, your results are going to be even better. Gabby, I'm going to show one more case, a little bit more complicated case, and how we handle that where we don't have proper interceptal bone, and how we can maintain form and function for our patients. So this patient presented to the office, obviously had dentistry, and had some splinted crowns, pretty bad shape. But the contralateral maxillary teeth are really in good shape. So this is a challenging case. To do half the mouth is challenging. And I think we all agree that these teeth were deemed non-restorable. So what I did here is I made the patient a flipper that they would wear during the healing of the implant and the grafting material. Now again, this is not a grafting course. We can show this again, the surgical application, but we're going to reflect the tissue to see the granulation, the infected area, the bone defects that are in the mouth. So we have an issue that needs to be corrected. So I'm going ahead and scraping out all the granulation tissue, and I'm placing my implants. Now you can see that I do not have a facial wall in a couple of these implants. But I also mentioned earlier that I can grow bone pretty predictably today. If I have mesial and distal facial plate of bone, I can grow bone very predictably. But again, there's certain rules that must be followed. Here I'm using a resorbable membrane from Newport Biologics from the Mish Institute. And you cut it to size. When we're doing a graft with an allograft material, bone from another human, we must protect it from invagination of epithelium. Epithelium normally grows about 10 times faster than bone will. So if you're going to graft, you must protect it. This membrane must be placed at least 2 millimeters beyond any defect, apically and mesial distally. If we're able to do this and this membrane is maintained for at least 6 weeks, we will get bone healing and bone growth in this site. Here I took my allograft material again from Newport Biologics. It's wetted with sterile water in this situation, and I'm repairing all the defect in that area. I'm then taking my membrane and protecting that graft from invagination of epithelium. That membrane must be placed passively, and it must be maintained for at least 6 weeks. This is a resorbable membrane. It lasts a lot longer than that. So the technique for placing that membrane is very specific. You must feel comfortable reflecting the tissue and making things heal. So our closure is done. These are vicryl sutures. And you can see my positioning of the implant and the grafted site in the area. After about 3 months of healing or 4 months of healing, we will expose the implant. And I'm not sure if everybody is familiar with this. Here we use an open tray technique. This is called a Mira tray, M-I-R-A, Mira tray. And it's a stock tray that you can get from your dental suppliers. But when we're doing an open tray technique, what we normally would do is we would take a stock tray and drill holes through it, or you would have a custom tray and drill holes through it. And the problem with that is sometimes we lose our stability. So this stock tray has like a kind of like a saran wrap coating, like a thick saran wrap, so that you can actually see where the open tray screws will pop through. So it's nice. If you haven't seen it, it's a nice tray. The laboratory will fabricate custom abutments in this situation. And here, these are seating guides that the lab always provides us. Remember, we torque test the implant to make sure that they integrate properly. But their implants bone doesn't heal completely for about 52 weeks. So we must torque these abutments in at 35 Newton centimeters with the Hahn system. And so they will fabricate these little seating jigs that allow me to torque the abutment screws properly to 35 Newton centimeters without damaging the implant itself. If the implant hasn't healed completely, it's very easy if you're torquing a screw in to have that implant move, which means it's going to fail. The laboratory fabricates for me what are referred to as smile composers. These are not for the patient to wear. These are for me to evaluate occlusion and basic shape of the teeth. It's very easy to adjust this acrylic material as opposed to the final porcelain or Bruxer work. And if the patient approves it and I'm happy with the occlusion, we can evaluate it. We can show the patient. We can make any changes. And here, because we have so much bone loss, we're going to end up with pink porcelain at the gingival level so that the teeth, the white part, are going to look natural in length. And then we will fill the defect with our pink porcelain material. So we're just doing a shade selection. And here our laboratory fabricated a nice Bruxer aesthetic bridge with gingivally shaded gingiva in the area. And we're able, again, to provide this patient pretty adequate function, excellent function, and acceptable aesthetics for the patient. Again, nice healthy areas. The patient will be given a water pick to clean the area. And we have a patient that was pretty darn happy with the final result. And this is certainly within the realm of all the general practitioners out there. So Gabby, I know I talk relatively quickly, but I wanted to cover the information that you requested from me. And I know we probably have some questions, and I wanted to respect everybody's time and finish up within the hour.
Tim, you did great with the cases, with the presentation. I can't ask for more. I really appreciate your time and the presentation. I have a question.
Yes.
When do you decide on using zirconia abutments versus metal abutments?
Well, that's a really, really good question. So, I've been doing it a long time. We've placed about 14,000. And so anything in a stressful area, I would probably use titanium. Now, the problem we have in the aesthetic zone is the material of the zirconia material that we use. When zirconia crowns first came out, we all complained that they were opaque and they didn't look very natural. And you can see the lab's able to do a lot with our zirconia today. And Glidewell Lab has different levels. They have their high strength Bruxer, and they have Bruxer Aesthetics. Sometimes with Bruxer Aesthetics, because it is a little bit more translucent, if we use a titanium abutment, the crowns will look a little gray. So in the aesthetic zone, I will tend to use zirconia abutments or gold-plated abutments for strength. I probably use more titanium, probably 80–85% of the time. And just in those special instances will I use zirconia abutments.
What's your intake on using zirconia implants?
Well, we just started. They're called Zirmax, and we just started their research for them here. They worked great. I only use them in the anterior area for aesthetics where bone is thin. The only issue that I'm having at this juncture is they're a fairly wide implant. They're 4.2 diameter. So you have to have a pretty good width of bone to be able to use it. They are coming out with their smaller diameter, like I think it's going to be a 3.5 or a 3.3, which I'm anxious to get. But the results we've gotten so far are wonderful. We will be publishing them in the fall, the cases that we've done. So they're working really, really well.
There is one question from Dr. Wang. Where do you buy the Osteogen again?
Impladent. IMPLADENT. Great material. Again, if you go to DrKosinski.com, it's just an education website. It has a lot of my research, a lot of my video demonstrations. I think that would be a great resource to get more information on the materials that I use.
Thank you, Tim. And let's see if we have any other questions from the audience. I don't see anything. Okay, guys, thank you for attending this webinar. Tim, again, thank you very much. Have a great day, everyone.